Hi everyone, and thank you for joining me for my lecture. My name is Susan Thorne, and I work at DentalVets in Haddington in East Lothian, where I completed my dentistry residency under my supervisor, Norman Johnson. So thank you for listening to my lecture today. What I'm going to talk about is lingually displaced mandibular canines in puppies and adults. And this is a condition that I think we are probably all seeing more and more of in general practice and referral alike. And it's one of these situations where it can be quite difficult to diagnose and explain to the owner about what treatments are best for the puppy and for the adults and why. So I'm going to go in a bit more depth about why we get this condition and the best ways to treat it. So first of all, we'll start off with the puppies. So we're talking about lingually displaced deciduous mandibular canines. This condition is considered to be multifactorial, so many factors involved in the creating of it. Is one of these situations that we need to have more studies into it to discover exactly why puppies are developing this malocclusion, although we do also know that there's a genetic component to it. So there is a complex autosomal recessive mutation which occurs to cause these cases. And that means that there is a 1 in 4 chance of puppies being affected. So if you have 4 puppies in a litter, then there is probably one which is going to phenotypically look like it has lingually displaced deciduous mandibular canines. And we're seeing this condition now more and more in previously many unaffected breeds. When I first started at DentalVets 7 years ago now, we mainly saw this in the Spinonis, which have always had this bred into them now, and it's very difficult to see Spinoni without lingually displaced mandibular canines. And now we are seeing it in a wide variety of breeds that we never saw it in before. So even such as your Labradors and your Spaniels, we're now seeing it in these breeds as well. And it is concerning, and we don't know if it's a breeding situation or if the vets are just picking it up more and they were seeing it, but we are definitely seeing this condition more and more now in referral practice. So why do we get this condition and what are the different types of it really? What you can get is you can get different classes of malocclusion. So you can get a class 1 malocclusion, which is on the right-hand side of the screen here. And what that shows is that this puppy actually has a nice scissor bite, so a relatively symmetrical mandible and maxilla of the same length. But what has happened here is that the mandibular canines are lingually displaced. So that's classified as malocclusion type 1 because they have the same length of the mandible and maxilla, but with the canines actually lingually displaced. And then on the left-hand side of the screen, what we have is a class 2 malocclusion, and that is also described as mandibular distocclusion. So what that means is that the mandible is shorter than the maxilla. And you can see here down on the bottom that we have a gap between the mandible and the maxilla, whereas the mandible should be relatively the same length as the maxilla with a nice scissor bite. And what you can imagine is as if you slot the mandible further back, then automatically that mandibular canine just slides right in behind that maxillary canine, causing this malocclusion. So these are the two types of common malocclusions that cause the lingual displacement in the deciduous mandibular canines. And these are the pittings that you can see. And this is often what you'll see when you see these puppies in the consult. You'll open their mouths and you'll see these pits in the palate. And that's what's often causing the pain that these puppies are displaying. Although we do often have many owners that come to us and they say, well, the puppy isn't showing any signs of pain, he's absolutely fine. And that is also very common. And that's because these puppies have this malocclusion from the minute that their deciduous teeth erupt. And so what we often say to the owners is these puppies just think that this oral pain is quite normal to them. So there often won't be a massive change in how the puppies are acting until we've actually done the treatment and relieved that oral pain. And then suddenly the puppies might start eating a bit better or playing with certain toys that they've never played with before. So often you can't, or the owners can't tell that the puppies are in a lot of pain until we actually perform the treatment. So mandibular growth is the kind of main concern as to how this condition develops. And from 7 weeks, most of the growth comes from the caudal mandible. So the mandible grows forwards. And what we do know from studies is there's no change in the mandibular length from the incisors to the molars from 3 to 6 months old. So the initial growth spurt in the mandible happens before these 3 months. which is why it's very important to jump in to treat these puppies early, because the mandibular growth happens very, very early in life. So we need to treat these teeth when the mandible is continuing to grow again. And again, there is a breed variation in this because larger dogs take longer to mature and to develop, and also toy breeds such as your toy poodles as well. So these breeds, the very, very large breeds and the very, very small breeds, will take longer to develop and longer to grow and mature, the same as teeth do as well. So why do we do this surgical extraction on these deciduous mandibular canines? Well, the first reason that we do is because we want to immediately relieve the pain from the traumatic contact with the palatal mucosa. You can imagine that every time this puppy bites down, then that deciduous mandibular canine is going into the palatal mucosa and causing pain. And so by relieving that, immediately gets the puppy out of pain. The other reason is that we want to relieve this dental interlock, because you can imagine if every time that puppy bites down, the tooth is pitting into the palatal mucosa and preventing normal growth of that mandible. And we do sometimes see mandibles that grow at different angles and funny angles because of this interlock, because as the mandible is trying to grow forwards, this deciduous mandibular canine is holding it in place and not allowing that growth. So by relieving this interlock, it allows the best chance for the mandible to grow the way it should do. And the third reason that we want to surgically extract these teeth is because we want to create a buccal pathway for the erupting permanent mandibular canines. So we know that the deciduous mandibular canines, when they erupt, the permanent mandibular canines will always erupt lingual or inside those deciduous mandibular canines. So if we have a problem with the occlusion on the deciduous mandibular canines, we're always going to have a problem with the permanent mandibular canines when they erupt. So when we do this surgical extraction, we remove the buccal bone, and we will go through this later. Remove the buccal bone so that hopefully it's going to allow a path of least resistance for that permanent mandibular canine to move into in a more buccal direction. So it's going to erupt in a more buccal direction than it would do if the deciduous mandibular canine was still present. So what do we do with these marginal cases? And these are the ones that we see, and we often get emails about it, that they look like they're a bit lingually displaced, but they don't have this automatic pitting that you often see. And it's the pitting that you see that's a worrying thing, because you see the tooth going in there and you see these pits and you think the puppy must be sore. So what I say to clients and to referring vets in these ones is do you see this pitting? Is there active pitting there that's causing this interlock and this oral pain? Is the interlock there that's going to prevent the normal growth of the mandible? And if there is, then those teeth should be extracted. And is the puppy experiencing signs of oral pain? So is the puppy eating well? Is it not wanting to play with toys? Is it behaving like a normal puppy? So if any of these three factors are present, the pitting, the interlock, or the oral pain, then I would be advising to extract these deciduous mandibular canines. However, if none of these elements are present, then this could be monitored, with the owner being very aware that we have recognized that there is a very slight lingual displacement, but none of the factors are there at the moment to indicate going in and being invasive with this case. So when should we be extracting these deciduous mandibular canines? Well, as we know that most of the growth happens before 3 months of age, really once these puppies have been seen with this condition, there is no point in waiting at all. So the condition will not improve as time goes on. If anything, it will worsen, as the interlock is going to prevent growth of the mandible. So these are the puppies that often will present to you for their first vaccinations or their second vaccinations. And if you see the puppies at this point with these lingually displaced deciduous mandibular canines, then you are best to advise extraction at that point. And again, the cases with a class 1 malocclusion, where there is a normal scissor bite with the maxilla and the mandibles, then these ones often do better when it is performed before the 12 weeks, so before 3 months of age, just because we know that's when the growth of the mandible occurs, and they often do best with those. The cases with the class 2 malocclusion, where we have the discrepancy in the mandibular length compared to the maxilla, I always advise owners that if I see that large discrepancy, then even if we treat the puppy at this point to relieve the oral pain and the interlock, there is still a high chance that we're going to have to treat the permanent mandibular canines when they erupt. And that's just because this mandible is never going to catch up with the growth of the maxilla. So we're always going to have this mandibular disc occlusion present. So if that mandible is not going to catch up with the maxilla, then the mandibular canines are probably going to erupt not in the correct position. So with those class 2 malocclusions, you can get the owner on board with monitoring and sending you pictures of them as well, just to see how everything's developed. And the cases that are found at about the 16 weeks old or a little bit older, and that's very common at the moment because we've had lockdowns, so we've not all been able to see these puppies as regularly as we would normally have wanted to. Often at that point, your permanent teeth are beginning to erupt. And when you see the puppies, they'll have permanent incisors and permanent premolars already beginning to erupt. And at that point, what we always say to the owners is that because we've not managed to find it early enough, it's probably not going to affect the buccal eruption pathway of the permanent mandibular canines. So in those cases, I would be extracting the deciduous mandibular canines if there was oral pain associated with it, if the puppies were painful and there was a severe interlock. However, I would be warning the owners that because it's a little bit later, it's probably not going to affect the eruption of the permanent mandibular canine, so further treatment may still be required. And you will also find that by the 16 weeks of age and older, it's going to be harder to remove that buccal bone plate that again we'll go through, just because the bone has got harder and tougher to be able to take away. So the extraction technique, and this is what everybody gets worried about with these deciduous mandibular canines. We know that the puppies are small, everything is more tricky. We've got permanent teeth very, very close by. So I'm going to go through it step by step on how we extract these deciduous mandibular canines. So first of all, always take a pre-op radiograph. This is just to show you exactly where the deciduous mandibular canines are, and you can see them down here. This is the deciduous mandibular canines on each side. This is the buccal bone plate that is going to be removed to allow the eruption of the permanent canines. And these are your permanent canines down here. And what you can see from this x-ray is it's extremely close to these deciduous mandibular canines. And because of that, we need to be very careful when we're extracting these deciduous mandibular canines that we don't touch these permanent teeth that are just behind at all. Otherwise, we're going to cause defects to them. So, and the other reason we always want a pre-op radiograph is just to show exactly where we are and to show what we started with. Remember that for all cases, we need to have evidence of what we've done. So a pre-op radiograph just shows what we've done at the beginning, and we will then also take a post-op one as well. So we want to make this procedure as sterile as we can. We know we're in the mouth, so it's not going to be a completely sterile field. However, we want to make it as sterile as we can and keep all the hairs away from all the surgical sites. So we use disposable drapes and staples for each patient. These are staples that just attach on, and it makes everything nice and neat as well. It means we don't have any towel clamps getting in the way, and they're quite abusive to the soft tissue in the lips as well. So making everything as sterile as we can and nice and neat and keeping all of the hair out of our surgical sites. Then what we're going to do to get access to this tooth is we are going to use a wide-based mucogingival triangular flap. So we're going to create our vertical releasing incision down at the mesial aspect of the canine, and then on the distal aspect running back, missing the frenulum. So this is your frenulum here. So we're going over the top of the frenulum as well, not going through it. We should always try to avoid the frenulum where we can. And we want to make sure the incisions are long enough, so they're going to go beyond the mucogingival junction so that we can then peel back that gingiva and mucosa and have nice access as well. We're then going to use a full thickness mucogingival flap, and the way to lift this is using your periosteal elevator. This is also known as your Molt 2-4, and it's one of the most vital tools in your extraction kit. And so what you're going to do is peel back all of this nice flap to expose the bone that's underneath. So there you can see that's the bone nicely exposed in there. And you can see your deciduous mandibular canine on all this nice bone exposure. So what you can see there up to about here is probably a third of what the tooth actually is, and the rest of it is lying right the way along there. So this is why we have to be so aggressive with these cases and remove so much bone, just because the roots are very, very long and very, very fragile because there's so much pulp there. So to remove this one, we're going to remove all of the flap right down. Again, you can use your thumb to help support it, but what you want to try and avoid at this point is any breakage of that flap, because you want a nice flap to be able to close it again. Then what we're going to do is we're going to remove the buccal bone from the outside of the canine. So you can see this is the root going all the way down there. So, and the way that we're going to shave that off is we're going to use our periosteal elevator. So that's just going to peel that bone away. So you just put it down between the buccal aspect of the tooth and the bone, and you peel off that bone. And because these are puppies, the bone is very, very soft. So it is much easier than it sounds. What you're not going to do is do any drilling or using any round diamonds, which is completely the opposite of what we normally do for extractions. Normally when we teach extractions, we're saying you always want to use a lot of exposure, a lot of bone exposure and tooth exposure to see everything. This case, we're not doing that. And the reason we're not going to do that is because when we have erupting permanent teeth around, we don't want any heat damage. So the minute you put your drill on there, you have a lot of other teeth that are unerupted, which are at a very crucial stage of eruption. And if you use your drill at this point, you can damage them and either cause defects or cause them to become non-vital, and then they won't erupt, which will cause a lot more problems later on. So no drilling, just shaving off that buccal bone on the root surface. Then what you're going to do is you're going to luxate the root mesially and distally. So only putting it in mesial aspect and the distal aspect. What you definitely are not going to do at this point is to put any sort of luxator or elevator down the lingual aspect, because the minute you slide anything down the lingual aspect, you're going to touch that erupting permanent mandibular canine. So only erupting at the mesial and distal aspects of that tooth. And by this point, because we've removed so much buccal bone, these teeth at this point will want to come. So they don't have that much attachment. So just a small luxation mesial and distally will help it to come away. And then what you're going to do is you're going to lift it bodily from that alveolus. These are extraction forceps. And so you're just going to lift it out. What you don't want to do is do any rotation. So again, unlike other teeth when we're extracting, and we do slight rotation to get them to come out, what you want to do is just lift them out the way, the direction that the tooth is shaped. You want to lift out in that direction. As again, if you rotate, then what's going to happen is the bottom of the root down here is probably going to move in the way and touch your permanent mandibular canine. So no rotating. At this point, the tooth should just be lifted very easily out of the alveolus. If it is not lifting easily, then again, you may need to remove some more buccal bone or do again a gentle luxation at the mesial and distal aspects. So at this point, if you see any large bone spicules or loose bits of bone, take them away and flush the site with sterile saline. What we don't do at this point is, again, what we do for other permanent mandibular canines, is you don't want to do any bone rasping or smoothing off of the bone, because again, we've got these permanent teeth that are in the middle of erupting. So what we do is you just take out the tooth and then close everything over. So any large bits of bone or anything there can be removed, but no other prepping of that site. And then we're going to close the flap tension free. Again, just replacing your mucogingival triangular flap. And again, just the way that we do it for the permanent teeth, we're going to make sure that we cut that periosteum just to allow that tension to be released. So plenty of cutting the periosteum. In puppies, it's exactly the same as with adults, and that will just allow the flap to come back up. Then we're going to suture the site with simple interrupted absorbable sutures. We use 5-knot monocryl for all of our puppies, no matter what the size is as well. And for puppies, I always say we would always use more sutures than less, because we know that a puppy is going to go home and it is going to rub its face on the ground. It is going to play with toys no matter what we say. So for puppies, I would place a suture every 1 to 2 millimeters, and you want the tails of the sutures to be 2 millimeters in length. And that means that they're not easily going to fall out as well. So then what we always do then is we lay the extracted tooth onto the surgical site, just as we have done in this picture, and that just shows how large these teeth are. And you can show this to the owner, and show them to the breeder as well. And it just shows how much root there is that we have to remove. And again, it's good to be able to see that when you take out these teeth, if you do have a ragged edge at where the apex should be, we've probably got a bit of root there as well, that's been left behind, and that should be retrieved. So you should be able to see a nice shape of the tooth and a nice rounded apex as well. And then again, we're going to repeat our radiographs. So we're going to take our post-op radiograph, and that's just to show that we haven't left any roots behind. We've taken away all of the deciduous mandibular canines. There's no damage to any of the other surrounding structures, and it can also show that we've removed a nice bit of that buccal bone. So now hopefully there's that these permanent mandibular canines, when they erupt, they're going to erupt in a more buccal direction because we've removed that buccal bone. So post-op counselling, this is to the owners. We always do this in writing. We know how worrying it can be for owners to bring their newly acquired puppy as well. And they're very, very small, and there's always a worry about anaesthesia in younger puppies too. So we always put this in writing because they tend not to hear much of what we are saying, apart from that the puppy is okay. So what we always say to them is that those surgical sites need to be protected for 7 to 10 days. And that's by feeding the puppy soft food and limiting soft toys as well. We do not give out buster collars with puppies, just because we find that if you give out a buster collar with a puppy, that it's going to do more damage trying to get the buster collar off than just leaving it and making sure the owners watch it all the time. We also used to say no toys at all. And then I bought myself a Vizsla puppy, and I suddenly realized how ridiculous that was. And if you didn't give them any sort of toys, then they would chew your furniture, chew your house, chew your legs. So now I always say to owners, they can have a toy, but it has to be as soft as possible. So something like, a puppet, a plush toy, something that's very, very soft. Just something so that they can hold in their mouth and take away that urge to chew a table. And for analgesia as well, we always would give out non-steroidals. So for post-op swelling and also pain relief, we also give intraoperative paracetamol and paracetamol home. Sometimes that is enough for these puppies. They do not need a full opioid. Although again, depending if you had to be very aggressive with taking away the buccal bone removal, then you can always give an opioid home as well, just in case. What I don't like is these puppies going home and then they're very, very painful at home, and then they have to come back to you as their general practice vets. So we do sometimes give out opioids if required. But what we are finding more and more now is that when we're using non-steroidals in conjunction with paracetamol, is that it's not required. And we give this report to the owner so that they can read everything once they get home, so that they can always refer back to it as well. And we also send them images home of the malocclusion before and then after as well, just so they can see exactly what we've done. And we say to the owners that we would now like them to send us images of the permanent mandibular canines as they erupt. And this is from about 18 weeks of age. So the images we want them to send us is when they can see the tips of the mandibular canines beginning to erupt. We want them to send us images with the mouth fully closed and the lips pulled back, because at that point we can decide how's the position of the mandibular canines looking. Are we going to have to do further treatment, or is there something like ball therapy that we could initiate before having to jump in and do further treatment to the permanent mandibular canines? So what can go wrong? This can go wrong. These are enamel defects to the permanent mandibular canines. So you will not be able to tell if this has happened until your permanent mandibular canines have erupted. But what you can see here is this brown part of the tooth is where the enamel has been destroyed and there's tertiary dentin being laid down there. So you can see the grooves out of the enamel. And this, when the puppies have had their deciduous mandibular canines extracted, is generally from the extractions where luxators have accidentally, or the root of the deciduous mandibular canines have hit this permanent canine as it's been erupting. And as the permanent mandibular canines are erupting, the enamel is very fragile, so just a small touch can cause these defects. And we always make our clients aware when they're coming for the procedure that this is a possibility. So it happens to all of us, happens to the best of us. I don't believe that anybody can take out these deciduous mandibular canines and never cause a defect. It does happen, especially in the very, very small puppies when there's just no space. But what we say is that we accept that this is a side effect and that if this happens, we will repair this free of charge. So we will solve this problem for them. And the way we do that is if everything is in the right position, we restore these defects. So we restore them with a flowable composite. And what that does is it just seals over these defects, because these defects here are actually exposed dentin. And exposed dentin is very sensitive, as there's nerve endings in each millimeter squared of dentin. There's actually 40,000 nerve endings. So it can be very, very painful and sensitive for these puppies. So by restoring these teeth with flowable composite, it takes away any sensitivity. So once these permanent mandibular canines have erupted, what are we looking for? So hopefully they're going to erupt into an occlusion such as the one on the left. So we have no malocclusion present. We've got a canine sitting in the really nice space up between the maxillary canine and the third incisor. But what can happen is we can also have the permanent mandibular canines erupting lingually displaced. And it's these ones that then we need to think about what the next steps are we're going to do for these adult. So what are the different treatment options we can do for lingually displaced permanent mandibular canines? One of the options are that we can do surgical extraction, so we can extract these permanent mandibular canines. This is something that we often want to avoid as much as we can. These are very, very young dogs, and it is a very, very invasive procedure to extract their permanent mandibular canines. Similarly to the puppies, what you can see is about a third of the tooth. So the rest of that tooth is actually lying along the mandible. So to extract these permanent mandibular canines, you need a lot of buccal bone removal, and to extract them, we would find that the dogs then find it harder to pick up objects as they use their maxillary canines and their mandibular canines, like fingers and thumbs, to pick up objects. So they will find it harder to pick things up as they continue to mature. You will also find that there's a tendency for the tongue to fall out of the side that the canine has been extracted on. It is something that we do offer. Some people just want extractions, they don't want anything else. But there is also the risk of a jaw fracture. So when you're extracting permanent mandibular canines, you should always warn the owner, because we're having to remove so much buccal bone, then there is always the risk of a jaw fracture during the procedure as well. And because of this risk, often if we are extracting mandibular canines, we will stage the procedure. So we will treat either the right side or the left side. Then we will send the dog home for about 4 to 6 weeks to recover. And then we will treat the second side in about 4 to 6 weeks. One, it allows the dog to recover from a big invasive surgery. And two, it allows the treated side of the mandible just to build up a little bit more new bone that's there, so we don't completely destabilize the mandible. The other option that we can do for these teeth are orthodontics, and we will go through some of the options of those, which is to move these teeth into the correct position. And then the other option is an endodontic procedure, which is crown reduction and vital pulp therapy, which is one of the most common procedures that we do at DentalVets. So extraction, as we said, these are very, very big teeth, a third of them that are there, and this is all within the mandible. So a lot of tooth to remove. You can see this is the immature tooth, because we've got a wide pulp chamber down here, going all the way down to the bottom of the mandible and all the way down to underneath the second premolar. So a big tooth in there. So extraction, you take away a lot of bone, and it does, you can see the kind of deficit that it leaves behind as well in there. And again, closure, nice closure with everything as well, and everything should heal well, but it does slightly destabilize the jaw for the immediate post-op. So the dog should go home being very careful with that side for a couple of weeks. Ball therapy is another option for orthodontics, and it's probably the least invasive, and I've been doing it more and more at DentalVets with very good effects and results. And this was first published by Lena Verhart, and where we're using a ball to push these mandibular canines in a more buccal direction. So you can see the ball in this dog's mouth here, and by biting down on this ball is actually pushing these canines out the way. So it's an inactive orthodontic device. And the size and the timing of this is very important. So the size of the ball is extremely important with ball therapy. And again, this can work when the permanent mandibular canines erupt. This can work up to about 8 or 9 months of age. But as the dog gets older, as the bone thickens and becomes harder around these mandibular canines, it does take longer to move the tooth through the bone. We should never use ball therapy with deciduous teeth. So deciduous mandibular canines, you cannot use ball therapy. And the reason for that is that if you imagine you're moving the tips of these canines out the way with a ball, if this was a deciduous tooth, then the bottom and the apex of the tooth is actually going to move further in the way. And at that point, it's going to hit off your permanent mandibular canines. So ball therapy should only be used for permanent mandibular canines and not for deciduous mandibular canines. So how do we do the measurements? The way that we find the right size of the ball is that the diameter of the ball should be the distance between the left and right mandibular canines plus 50% of that size. So for example, if you measure 30 millimeters between the left mandibular canine and the right mandibular canine at the tips of those canines, then you're going to do 30 millimeters plus 15 millimeters, which is going to make a 45 millimeter diameter ball. And then it's trying to sort these for the viewers. Amazon are great, just typing in 45 diameter ball. Kong have very good ball options as well, but really it's up to the owner to go around with a ruler and try and find an appropriately sized ball. What we would say is that the ball, if you are in between two sizes, go for the bigger ball than the smaller ball, because a smaller ball is just going to sit in between those canines and not do any pushing action. So what we want is the actual pushing, because what it's going to do is push the teeth from in this position to hopefully this position. So you can see that this has worked really nicely with ball therapy, just pushing it out in a buccal direction. And once the owners have sourced this ball, then the dog should play with the ball for at least 15 minutes, 3 times a day, and keep the dog interested as well. So what I would advise the clients to do is to keep this ball as a special toy. So only give this ball to the dog for those 3 times a day for 15 minutes. And after 10, 15 minutes, take the ball away to keep the dog really interested, as otherwise the dog will just think this is an everyday ball and they'll get bored of it. And also you can use balls that have, say, got holes in them to put a little bit of food in it as well to keep the dogs interested, but you want to keep it as something special so the dog really looks forward to using this ball, and then he'll keep on biting down on it again. So an incline bite plane, this is another orthodontic device that can be used. So we have a situation here of a lingually displaced right mandibular canine. And what these incline bite planes do is that you put it around your maxillary canine and then spreading up to your third and sometimes second incisor to here. And so what that's going to do is then you are going to guide this tooth into the right occlusion. So you're pulling it effectively from this position out into this position, because every time the dog bites down on this incline bite plane, it's going to be pushing it out the way. So it's going to be pushing it over those ones as well. Now, the disadvantage to this one is it does only really work in very marginal cases, because as you see, if the tooth is too far in, then you're not going to be able to get this right angle as well. So it works better on the marginal cases for these ones. But again, you could probably use a ball therapy in this situation, and it's least invasive than having these incline bite planes. The other disadvantage to an incline bite plane is that depending on the dog, it could go home and bite down on something silly like a stone or just aggressive play, and it's going to manage to break off these incline bite planes. And it is common that these can break off. It is acrylic or composite that's used to create these. So the dogs have to be very careful when they're at home with what they're putting in their mouth and what they're playing with. The other disadvantage is, as you see, once we have taken off this incline bite plane, then you do have this gingivitis underneath. And that's because we've had effectively this covering of this composite or this acrylic, and it's got this gingivitis underneath, and that will resolve. Often the dogs will just need a non-steroidal to take away any sort of pain and inflammation associated with it. But they do work quite well in marginal cases. We use them less often. I prefer the ball therapy as it's least invasive. And the other question with the incline bite plane is it's not particularly scientific with it. So when you're creating this incline bite plane, this plane to try and push it out the way, it's kind of sometimes guessing as to what the angle is. It's very difficult to get it very accurate each time. And the other option that we can do for orthodontics is an active force. So active force nasal chain is what this is called. And the reason it's called active force rather than passive orthodontics, which is what we've been talking about before, is that this is actively pulling these teeth all the time. So it's not relying on the dog to be biting down and then it's passive. It's actively pulling the teeth into that position, a little bit like when you get braces as a child. So what we can see with this dog is that we've got a malocclusion because this right mandibular canine is lingually displaced, also because it's sitting behind this right maxillary canine. So the aim of this is to pull this right maxillary canine further backwards to allow space for this right mandibular canine to fit between the third incisor and the canine. Now, the disadvantages to this is, again, these chains can break. And also these buttons that are attached to the teeth with acrylic can also come off. So when we do this at DentalVets, which again, we quite rarely do this, we always want the owner to be fairly close by, because if the chain breaks or if the button comes off, then we need to replace that. So if they're living 4 hours away from us, they don't want to keep on coming back down. And again, the disadvantage is that every time, say, a button needs replaced, it's a full anesthetic for that dog as well. So if each time we're having to replace anything or check it, it's being anesthetized each time as well. The owners can get used to replacing these chains at home, and we can give them reels of this nasal chain, which is made of rubber, to replace at home if the dog is quite compliant, and we'll let them hook these around the buttons while it's conscious. And again, when we're doing these active forces, we would be wanting to review the occlusion every couple of weeks. So every 2 to 4 weeks, we would be wanting to see the dog again, just to see how it is. Occasionally, either these reviews will need to be anesthetized or conscious, depending on how the movement is going. And then the other one that we can do for these marginal cases is just gingivectomy. So if you have a mandibular canine which is just sitting very, very tight to the gingiva, not actually causing active pitting and indenting, but sitting very, very tight and causing inflammation around here, you can do a gingivectomy with your diamond burr just to create a groove in this gingiva to allow the mandibular canine to grow up. And then by allowing the tip of the mandibular canine to actually start to grow up over the gingiva means that as it continues to erupt, it will force its way into the right direction. And this is a very good option for those marginal cases, just to help guide it into the correct position. Crown extensions are also another orthodontic option. And again, these cases should be reasonably marginal, but what we can see on this left mandibular canine is that it is not quite fully erupted into the right position. So it's getting stuck in between this mucosa and gingiva between the canine and the third incisor. And it was causing a pit in here and also active inflammation. And the dog was quite inappetent and hypersalivating from the pain that it was causing. So what you can do with crown extensions is you, as it says, you basically extend the crown. So we're going to extend the crown, again with composite or acrylic, up in here. And what we've done with this one to accompaniment is a small gingivectomy, just to guide the tooth up. And then we've extended the crown, because then as the tooth is continually erupting, because these cases that we're seeing are normally about 6 months of age, so we've still got a good 3 to 4 months of eruption of these teeth. And as they erupt, this crown extension is just going to guide it into the correct position. Whereas if we'd left it in this situation, as it erupted further, it could just pit further up into this gingiva here. So the crown extension is guiding it in the correct position, also helped by our gingivectomy there. And again, the disadvantages to your crown extensions are that they can fall off. So again, the dog can go home and it can bite down on something and break off your crown extension, which means the dog's going to have to come back and see you again, and again be anaesthetized again to replace these crown extensions. The other thing with all of these inactive orthodontic, with all these active and inactive orthodontic appliances, is that we can't guarantee the right outcome. So we have to always say to the owners, this is what we are hoping for. We are hoping to get a non-traumatic occlusion, but it doesn't always work. So we can't guarantee that at the end of this, with all of their efforts and the dog's efforts, we are going to have a non-traumatic occlusion and not have to do further surgery anyway. So this is the procedure that we regularly do at DentalVets. Anybody that refers to us regularly will know that this is our preferred treatment of choice for these lingual-spaced permanent mandibular canines. And what we have here is we've got lingual-spaced right mandibular canine. Again, you can see it's a MAL2 because we have this disc occlusion. So the canine is going up, sitting palatal to this right maxillary canine, and again exactly the same on the left side. So what we do with this crown reduction and vital pulp therapy is we shorten the crown. So we take off the top of the crown, so the owner should be aware that these canines are never again going to be pointy, and they're going to be shortened down, which will then purposefully expose the pulp of the tooth, and we are going to place an MTA filling on the top of the pulp, which is a biologically compatible cement, and that's going to keep the pulp alive and allow the tooth to continue to mature as the other teeth are maturing. So we're not killing the tooth, we're not damaging the tooth, everything should still continue to mature, and these teeth, when they've been shortened, should also continue to erupt. And the reason that we like to do this procedure over other orthodontic procedures is that it immediately relieves the pain for the dog. So the dog comes in, gets the procedure, and when it goes home, the pain is relieved. And we have got a very, very high success rate with this procedure as well. There is also always the chance that because you are touching and dealing with live pulp, then some of these teeth may not survive. But we do not find that happens very often. We have a very high success rate with them, but the owners have to be aware that there is a chance that these teeth could become non-vital as well. So this is what the procedure is. You can see this is a right mandibular canine and a very immature tooth because we've got a wide pulp chamber and we've got an open apex down here, so an open end of the tooth. And that's showing us that these teeth still have further eruptive potential. So this tooth is going to continue to erupt and it's going to continue to erupt into the wrong position unless treated. So what we do is we take off the top of the tooth, taking off the crown here, and this is our MTA filling material. So that is in the top of the tooth, and then we put a little composite restoration in the top of it. So this is what the tooth is now going to look like. So we've taken off the tip of the canine. You can see what it looked like before compared to that one. We put our filling material in, our composite restoration on the top. So the tooth looks like a normal canine with a flattened top as well, and that's going to relieve the traumatic contact that's there. And this is what we would need to see. So this is immediately post-op. So we've got the wide pulp chamber and the open end as well. And because these teeth, we want to see that they're maturing, the disadvantage of this procedure is that we need to see these teeth again, and we see them 4 months after treatment and then 16 months after treatment. And what we want to see is that these teeth are maturing. So this tooth has nicely matured. You can see the pulp chamber has got a lot thinner, which means it's maturing. We've got thicker dentin walls, so a stronger tooth with the tooth maturing. We now have a closed end to this tooth, so a closed apex, which means that now at this point there is no further eruptive potential of this tooth. And what we can also see is there is a nice dentin bridge formed underneath our filling material. And that's because the tooth recognizes that dentin bridge and lays down its own bridge in there. And the fact that we've got no pathology down at the apex as well, so we've got no abscesses forming, we've got a nice maturation of this tooth, then we can indicate that this tooth has stayed alive and has remained vital. So as I said, we always do a review in 4 months and then 16 months, and you can see the dramatic maturation of this tooth from 4 months to 16 months. And as you can see, at each review, we also check the occlusion again. So before the dog is intubated, we would check that there is no traumatic contact between the canine that we've shortened and the mucosa on the top as well. and also check the access restoration. So this is the little access restoration here that's made with our composite. And if there is any damage to that, well, then we would repair that at the time as well. So it's vital that we have these 2 reviews just to make sure that this tooth is maturing. There we are. So this is your crown reduction and vital pulp therapy of these teeth in the post-op one as well. And these are the pits that we can see that form here. So which option is the best for the dog and also for the clients? So really what with these ones, with the decisions that we need to make, is we need to involve the client in them. You know, what do they want to do? What are their expectations for the dog? Are they going to be able to provide any home care as well? Is the dog very, very active? They're not going to be able to look in its mouth. They don't think the orthodontic appliances are going to work. We need to see what they're expecting from this as well, and guide them into the right direction for them and for the dog itself as well. Also, the clients need to be aware that there will also be reviews and other general anaesthetics required for any of these procedures. So it's not that it's going to be done today and then the dog is going to be fixed forever. There is always going to be reviews involved in all of these options as well, because either we're trying to review that these teeth are remaining vital and staying alive, or we're also removing orthodontic devices, or we're altering the orthodontic device as well as those teeth move into the right position. They also need to be discussed, you know, the success rates. What are they expecting? Do they know the benefits of everything as well? And a lot of these procedures, the dog may feel some discomfort. Say if they have an inclined bite plane, they should be expecting gingivitis. And the dog will wake up feeling like it has something on its teeth, and some dogs just will not tolerate orthodontic devices at all. And that needs to be expected as well. And then the other concern that we always have is an ethical concern. So when we perform this crown reduction and vital pulp therapy, it's obvious at that point when anybody looks at this dog or say in a show ring, then these dogs have had crown reduction and vital pulp therapy. So they know that they have had an occlusion problem from that. The concern with using orthodontic devices is that you are moving teeth that are not in the correct position into a correct occlusion. So at that point, just by once the teeth are in the correct position, then by looking at the dog, it's not going to be obvious that there was ever a problem in that occlusion. And so for those reasons, when we are doing orthodontic devices or orthodontic appliances to move teeth into the correct position, we will always ask that that dog is neutered before we do that procedure. And that's just because we don't want that dog then going on and breeding and exacerbating the problem with the breeding of this condition. And similarly, I would never want to perform this procedure of an orthodontic movement in a show dog, because if that dog then goes into the show ring with a perfect occlusion, that's a man-made occlusion. So there was a genetic problem in that occlusion. And by moving these teeth orthodontically makes it look like it has a perfect bite. And what I always say to the owners is it's not similar to us. We all want to have perfect looking teeth when we smile, and the dogs really don't. You know, they don't care if they have a perfect bite. They don't care if they have a perfect smile. They just want to be comfortable. So they want comfort and they want to be able to act normally like a dog as well. So that's always our aim in treating these malocclusion cases is comfort primarily, and for the dog to be able to act normally as well. So if there are any questions, then I would be happy to answer them. The best way to contact me is at the DentalVets email address, which is reception@dentalvets.co.uk, and I would be happy to answer any questions that you have about this lecture or about malocclusions in general. Thank you very much all for listening, and I hope to see or speak to you all soon.